Welcome everybody. Thank you all so much for joining us today. I'm Anita, Courtney, and I'm a principal in Russell Kennedy's aged care team. I've also got here with me my colleague Catherine Ellerman, who's a part of our retirement living team, and also my colleague Joanna Heaven, who works with me in the aged care team. So on behalf of Russell Kennedy, I'd firstly like to acknowledge the traditional owners of the land on which we're all gathered today. Our office in Melbourne is situated on the unceded lands of the Wurundjeri people, and we pay our respects to their elders past, present and emerging. So it's been a very exciting few months at Russell Kennedy. As you can see, we've moved into our new premises and I hope you like them as much as we do. We're obviously also very delighted to be hosting DCM's executive breakfast today. And on that, I will hand over to Chris. I look forward to learning more from the wonderful panel today.
Good morning, everybody. Thank you for joining us. Just a couple of housekeeping things before we start. The reason why I'm holding a microphone and you can't hear a microphone is because we're using it to record for the videos. The interest in this breakfast has been so great around the country that we decided at a very late stage that we were going to video it, and so we'll be able to make up something to be able to distribute to the rest of the sector at another stage. I'm going to do a brief presentation just to introduce you to hospital in the home and how we see that it may be impacting both the retirement village sector and the aged care sector, and then we will follow it by having a discussion with our panel. And on our panel we have, closer to me, Verity Leith, who's the General Manager Residential Services at Benetas, and Verity's been with Benetas 12, 14 years?
Five with Benetas.
5 years. Sorry, I apologise. Beverly Smith, Chief Commercial Officer for Amplar Health, and Paul Brindle, CEO of Health Metrics, and of course Anita, who in today's world we always need a lawyer in the room, and Anita is the expert in this area. So I'm going to take you on a quick journey if I can. We're a media group at DCM. We have the opportunity, the privilege to be able to meet and speak to a lot of CEOs, a lot of chief commercial officers, property people, lawyers, banks and what have you, and also government. And we look at what is happening in the retirement living and aged care space. And our why as to why we exist is that if we can be better educated, we're going to make better decisions and we're going to get better outcomes for our residents. And we've been looking at what is the direction of retirement villages and residential aged care over the next 5 years. And if you've attended any of our Leaders Summit, you would know that we're quite alarmed. The thing that is that's been bubbling behind the scenes with a number of large operators building up their arsenal to be able to effectively tackle the challenge that we have in front of us are all leading to technology and hospital in the home. And that's what I want to walk through today. So if I can make this clicker work. I'm going to start with statistics, and we're all tired of seeing statistics at a presentation, but I don't know how many people have actually seen this graph before. That red line is where we are today, or where we were in actually 2022, in terms of the number of people who are turning 80. And if I can ask you to take a step back and think that 2 years ago, what were the resources that we had for residential aged care and home care services? And 2 years ago and today, we're pretty maxed out, aren't we? And then if you look at the lines above the blue lines above the red lines, they're the number of people turning 80 each year. And if you do the simple maths, it was about 82,000 in 2020, and by 2026, it's going to be 40% higher. That means we've got right on our doorstep now 40% more people turning 80, which means 40% more demand for home care services and residential aged care services. Is that a good thing? What do we think? It's a bit of a challenge, isn't it? So the government says that home care is going to be the solution. Now, I've borrowed a Stuart Brown slide here, and as you can see, in 2010, a level 4 package gave you 17 hours of home care. That's somebody physically in your home giving you care. Today, a level 4 home care package gives you 8 hours, and it's going down with each successive year. So home care really isn't going to be the solution. The government, the department, recognises that home care is going to be a major challenge. So Nick Morgan, in his webinar in February this year, said the role of the care partner or care manager by 2027 onwards is going to be critical, i.e. we know we're going to be looking after people in their home, and we're going to have really strong care managers keeping an eye on them. And he also said that by 2025 we're going to have a level 5 home care package. So if you think about that, let's say it's going to be an $80,000 package. They're going to be expecting people who would normally be in residential aged care are going to be receiving a level 5 home care package at home. Are we in a fit position to be able to do that is the question. If we go to the retirement village sector, which many people in this room are accustomed to, the Retirement Living Council and stroke the Property Council earlier or late last year, December, developed a document called Shared Care. And this is their advocacy document going to the federal government to get retirement villages recognised as a legitimate place for people to age in place. And this is a graph that's taken out of them. And this is the pathway that the Retirement Living Council sees. So they say, retirement village setting will be able to provide basic low support, which will then go into intermediate support, then it'll go into high support in a retirement village, and then those people will transfer to residential aged care. So that's the pathway that the retirement village sector is saying. But there's a problem with that, and that is that we're not building enough aged care beds. So some of you may have seen this data before, but in FY22 we built 860 net new beds, 1,574 23, 520 in the first 9 months of 2024. So 3,000 new aged care beds in 3 years, when right on the doorstep of the number of people turning 80 increasing by 44%. This is not a good place for us to be. At the same time, Deloitte did a study and released it year before last, looking at the number of hospital beds that we've got, and they said in 2016 we had 96,000 hospital beds, and in 2036 they expect for us to have around 96,000 hospital beds. So you can see, if we had the right supply of hospital beds and aged care beds in 2022, when we get 44% increase in numbers, we've got a major problem. If we go back to the retirement village sector, which is one of our areas of main concern, the PwC survey identified that the average age of people in retirement villages is 80 today. It also found that this graph down the bottom here, if you can read it, the most common reason for exiting a retirement village is 55% go into an aged care bed, go to a residential aged care. What if there are no aged care beds for them to go to? 20% go into hospital, and what if there isn't a hospital bed for them? We're going to have a logjam, we put forward. So we have at DCM a customer hypothesis, and that is that the beds are full, we can't get one where you want it, and you can't get it when you want it. Baby boomers will not want to go into residential aged care. Anyway, especially if they have to pay for aged care. And the headline in the Australian on Saturday was $40,000 those people with wealth will have to contribute. So what are people going to do? They're going to grab village accommodation because they'll see it as a safe harbour proposition, just like they did in COVID. They'll get a home care level 5 package, and then they'll refuse to leave the village. Just think about it. They'll refuse to leave the village. And I'm sure Russell Kennedy will say that they've got a number of clients who are trying to exit people from their village home, and they just can't get them out. And that's been reported to us across the whole country. So our hypothesis is that within 5 to 7 years, it's entirely plausible that 100,000 retirement village beds will be aged care beds. Just think about that. 100,000 retirement village beds are going to be aged care beds. That means that 50% of all retirement village beds are going to be aged care. Now, what impact is that going to have on the retirement village sector? Well, first of all, villages will no longer be independent living, will they? The people who want to get into villages will be people with acuity, and they're not going to leave. The second thing is the village operators are going to have to change the way they market. They won't be able to say we are independent living. They're going to have to say we're going to provide care support. Why are they going to have to do that? Is because that's what they're going to have to provide. And the average residency is going to be 4 years, not 9 years. So if you look at LDK, if you look at Odyssey and those operators that have got a strong service department thing, the average, say, is 4 years, not 9 years. The operator's duty of care risk is going to take off. So we were talking earlier about retirement villages being a property play. Well, now it's going to be a medical and care play, which means your risk is going to increase dramatically. If the government is giving you $80,000 to support a person in their home, it's going to come with regulations. Village staffing and complexity will take off, because village managers who are accustomed to be looking after a property are now going to be looking after very sick people. The revenue complexity is going to take off. Because you've got all these additional staff and demands and so on, you're going to have to get new revenue streams. And the horizontal village model is inefficient, and close to 90% of villages in Australia are horizontal villages. And the final thing is that technology and hospital in the home partners are going to be vital, and that's what our discussion about is today. Now, why do I say horizontal villages are inefficient? So can you imagine, this is Belrose Country Club in Sydney. It's a Retire Australia village. It's a typical village. The place with all the solar panels on the roof is the community centre where the village manager is. But if 50% of all those homes have a bedridden person with high acuity in them, how are you going to service those people in all of those homes without a massive number of staff? I was talking to Byron Cannon, the CEO of LDK yesterday on the phone, and they own a village called The Landings. It has 240 odd homes. It looks like this. He now has 120 staff there, and he's got 40% of the people on home care packages. So, hospital in the home, that's why we're here. What is hospital in the home? I've taken this definition from the New South Wales Health site. It says hospital in the home provides equivalent or better outcomes at better value. So that's a government approach to hospital in the home. Their definition, this is New South Wales Health, is that hospital in the home is clinical care that reduces the length of stay in hospital, or in some instances can avoid an admission altogether. So for the state government with their local planning, local health authorities and so on, they're after reducing the number of hospital admissions. But is hospital in the home only clinical care? And the answer going forward is no, and we're going to be discussing that on the panel. The indicative roles that the larger operators who are moving heavily into hospital in the home say that their services are going to be about prevention and well-being, and they see that they're going to be delivering face-to-face activity in the home, telehealth, video, telephone, SMS, web chats, digital synchronous and asynchronous, telehealth, video, telephone, etc., digital remote monitoring. The wearables and digital appliances in the home is going to be with us within 3 years and at scale. In Denmark, they pride themselves as being a digital health nation, and everybody over the age of 75 has wearables and monitors in their home, and it's accepted practice. So I hope that gives, that's where my voice is finished. That's where we're up to. Can people see that journey? And do we believe it could be realistic? And do we see that at the moment we don't have the resources to satisfy the demand and the complexity? So, I'd like to now ask the panel, what do they think going forward? And I'm actually going to start. Bev, could I call upon you? Because Bev has recently joined Amplar, but with a long history of retirement villages, home care, residential care. You were with My Home Care for 2 years, so the largest home care provider. What does Amplar, part of Medibank, see going forward, and does it marry up with this?
Absolutely, Chris. So good morning, everyone, and lovely to see many friends here today and many experts on this topic in the room. Look, from Amplar's perspective, there's a couple of key drivers in this space. You know, Chris has touched on the shortage in terms of accommodation. Equally, there's the reality that we all face into every day around workforce and how is workforce better leveraged across this continuum model. There's also a key component here in terms of what our residents are looking for, people living in their own home in the community. So there are a number of factors driving this shift. And what we're seeing is more and more people looking for opportunities to have higher and higher levels of acuity of care delivered in their own home, whether that's in a retirement village or still their home in the community. Equally, what we see is a significant amount of technology coming into play. So in our model, the most significant delivery channel is through telehealth. So that's either through video or phone in terms of how advice, triaging, support can be delivered to people wherever they might be. So I think, when we sort of zoom out a little and look at this ecosystem holistically, you can see these macro forces driving really rapidly. And I think our opportunity is to sort of stand back and look at it holistically. Often we're drawn into, the dynamic between retirement living and aged care or retirement living and home care. When we stand back and look at the health needs of the people living in our villages, I think we've got an opportunity to sort of integrate what they're drawing out of their primary care, so their access to their GP and all of the services that GPs can connect people into, whether it's physical health, whether it's mental health, which is often an issue for our cohort. And then, in terms of their home care package eligibility, what services can be drawn down through that. And then finally, their private health insurance. So many of the people living in our villages do have their own private health insurance. There are a lot of services that people are not aware of that they could be accessing that are about helping them to stay well in the village. And ultimately, they're all motivated by the fact, as Chris said, they don't want to end up in residential aged care, and they certainly don't want to end up in an unplanned hospital admission. So how do we start to sort of make those options more apparent and available for residents in our villages?
Bev, can I just ask you to explain the journey for Medibank to being Amplar today? That journey started and strategy started about 7 years ago, didn't it?
Absolutely.
And could you also tell the audience how many virtual health interactions occurred last year, just to show that this is happening?
Absolutely. So the journey for Medibank and specifically Amplar Health did start sort of 6-7 years ago with some acquisitions to move the organisation from being a pure play private health insurer to actually delivering the care services. And the organisation's commitment to be able to deliver the proof point of health insurance, which is in fact the services that people can access, is very strong. About 12 months ago, that amalgamation of acquisitions was rebranded as Amplar Health. And we now cover a spectrum of services across clinical, allied health and GPs. So we don't hold a workforce that does personal care or domestic assistance. So we're sort of at the more acute end of service delivery. We specialise across 3 key domains. So we do what we would call home hospital. So this is through partnerships with state government. So for example, in South Australia, we have a model which is delivering basically a virtual hospital in a joint venture with Calvary and with the South Australian Health Government. We have a virtual sort of health delivery model, which is very much around all of our telehealth. And then the final area is around our preventative programs. So last year we delivered over 700,000 virtual health consults through our capability. We delivered over 4 million interactions through our GP network, and included in that was around 29,000 health check assessments to ensure people have early insight in terms of their needs. And that translated to saving the health system about 193,000 hospital bed days. So it's a model that really tackles that more subacute and acute end of the continuum.
So those are really big numbers, aren't they?
They are big numbers.
But that's the tip of the iceberg.
Absolutely.
And your geographic spread is not across the whole country at this point?
Yes. So we can deliver services to 93% of the postcodes across Australia. So there is a national footprint available, both in terms of physical service delivery, but also through our telehealth capability.
And you mentioned the expression frequent flyers earlier.
Look, I think with that, Chris, it's about understanding in particular the residents in our villages are people who are at that age and stage of life where naturally chronic disease prevalence is much higher. They are naturally the people showing up in emergency departments and hospitals with unplanned admissions. That is simply a fact, a statement of life. But I think what's important is how do we understand what more we could be doing in our villages to help arrest that sort of reactive approach. So from my perspective, as Chris said, 15 years in the sector, retirement living has always been this beacon of hope. It is a self-funded model. So the residents in our villages are people who chose when and where and how much they wanted to pay. So it's not the same kind of mindset of people sort of needing to go into residential aged care. Retirement living is an actual positive choice that people make because they want to stay in control and they want to make those decisions. The challenge for us is have the care models kept up with that? And so how do we start to make care available on demand where and when people want it, just like we've been doing in retirement living from an accommodation perspective? And I think our opportunity in the retirement living space is to engage with that health ecosystem to say, well, how do we start to make that more proactive and accessible for the residents in our villages?
Thank you. Verity, Benetas, major home care provider, major retirement village operator, major residential aged care provider, and always been strong on strategy. Looking forward, how do you see Benetas adapting to this new world?
Look, from an executive point of view, we talk a lot about leveraging the fact that we are in all of those markets, and then what would that look like to support people across that continuum. So, we've had a lot of conversations about I think we believe there will always be a place for residential aged care. There will be people that it doesn't matter what money they've got, what supports they do have, and they will still probably need a fair bit of informal support too, unfortunately, which is a big carer burden. There will be people that their age stage and the conditions that they're suffering from will require them to have a residential aged care, but I completely agree, it is not a lifestyle choice. None of us in this room, I'm sure, want to see ourselves end up in residential aged care, but I think it's comforting and hopefully getting better that there is that safety net there for people who really do need it. We certainly see that residential aged care is going to become more and more acute. I'm already talking about how to skill up nurses in terms of reskilling for some of them, use of IVs, a whole lot of things to hopefully unburden the hospital. It's ridiculous that we send people to hospital for a blood transfusion. It's ridiculous that we send people to hospital for some other things that we really should be able to manage in the home. We're fortunate, as I say, that we've got a home care business which has an in-home nursing service, and certainly I've had lots of conversations with Helen, who's the GM, about how do we get nurse practitioners in that cohort that are actually already IV capable, etc. There may be some, we're just not using it yet. Same with, instead of me buying a wound consultant, we've already got our wound consultant internally. So we're definitely looking at that. Talking to Chloe, who manages our retirement villages, certainly there are people already there, as you say, that are on home care packages. and that the village manager has a lot more responsibility, although it's, I guess, it's not formal, it's not formalised, but they are keeping an eye on a lot of people that they probably weren't keeping an eye on. I think the other one that could be challenging for retirement villages if the acuity of people living in them becomes higher and higher is I know from a residential perspective, sadly, our residents aren't always very empathetic to other people that are living in the communal environment, and I could see that becoming quite challenging in a retirement village if you're looking after people whose acuity levels are becoming higher and higher, and why am I looking at that every day when I've paid whatever I've paid to be living here? I think there's so many things that as a community we have to unpack. It goes to the whole thing about ageing, what is ageing, what's ageing well, the plans we need to be making proactively, all of us, about advanced care plans and what we do or don't want, and they're confronting conversations. And I think the other one that's a real hiccup for all of us is this Commonwealth state divide in terms of funding. You know, it's a whole lot of duck shoving and, cost shifting, and none of us really want to pay, but we all have to pay. We are paying, it's our taxes. And to your point, I think the other one with retirement villages, because I know we're not struggling, but it's a significant unfunded cost burden, the level of compliance in residential aged care that I don't think the Commonwealth is quite aware of, and we've done some metrics on some of that ourselves. So if that then goes down to retirement villages, then what does that mean? And what does that even mean for your cost structure? Because that's got to be built in somewhere. So I think there's big society questions that need to be answered, not just by providers, really. What does ageing well look like?
Well, there's absolutely no doubt that residential aged care homes won't go away, because we haven't even mentioned the word dementia. And in America, of course, memory care homes are a thing in their own right. But the home care labour force is a lot cheaper in America, so people can stay at home more easily. Paul, all of this is highly complex, and as Verity just mentioned, the complexity of regulation and revenue. As a group that develops the infrastructure for people to operate more efficiently, what are you seeing with your clients? And you need to be ahead of them, don't you?
Sure. Our customer base includes the traditional residential aged care providers that at the large end of town with dozens of homes and thousands of residents, right down to small not-for-profit single home providers as well. We also service residential independent living providers and also home care providers as well, and some of those like Benetas, for example, that cover the full spectrum. I mean, it's interesting, this topic of a hospital in the home is not a conversation I've had with any of our customers so far, at least not by defining and using that term, hospital in the home. Our business is and the service offering that we have through eCase is definitely evolving over time. I agree with the comments that there'll always be a place for residential aged care. Certainly some of our larger resi provider customers still have strong growth ambitions, be it either through acquisition or organic build out as well. And then we have some of the sort of innovative players in retirement living as well.
Well, you do have LDK and Odyssey, who are the flag bearers in this market.
We've got customers like that. We just took on Henley on Broadwater. They've got a high-rise resi, I think 30 plus story apartment living that they're going to use us to manage their village and manage the delivery of care as well. And so for me, when I think about hospital in the home, however it evolves and however it sort of manifests itself over a period of time, it's all about innovation. And I look back at the task force report over a year ago now, and recommendation 19 that spoke about the need for more innovation in the aged care sector, enabled by investment in technology. So the conversations we're having with our customer base and with the market more generally about what can we do as a technology provider to enable our customers and the market to be more innovative in what they're offering into the aged care industry, regardless of the setting. And whilst we're not talking about hospital in the home as a topic as such, when I sort of step back and think about the conversations we're having, it is about increasing and improving the service levels and the offerings and ultimately the delivery of care by our customers, by our market into their businesses.
One of the major trends with those Australian Unity, Amplar and Calvary is partnerships with mainstream health organisations, whether it be the public health networks or what have you. That seems to be what dare I say, the early pioneers are saying we have to partner with these groups because we're going to feed off each other. Is that a fair thing to say?
Yeah, I think there's a couple of different schools of thought there. I think there are some providers that feel that they need to own and manage and deliver the full service offering themselves. But that's obviously a big, that's a big leap forward for a number of the retirement living providers who are, traditionally property developers.
I think,
but there are others. I think that through a desire and a need to increase their service offering to attract more and to derive more and new revenue streams, I think that will drive more partnerships over time.
Yeah, it sounds silly saying this after my introduction, but these pioneers need scale, and therefore by partnering with a local area health network, that gives them scale. Am I right in saying that, Bev?
Absolutely, scale's critical in this space, Chris, and I think the quality of the outcome for the person, resident, patient, is very much determined by how well those different parts of the system connect up. And there are different pilots being looked at in terms of the interoperability. How are you sharing information across different delivery settings? So a great example of that, in the last week or so, the Department of Health have released a tender for the participation in virtual care delivery into residential aged care. So that's how you take a virtual nursing capability and start delivering it in residential aged care homes that currently can't meet their care and their RN requirements. So I think it's fascinating to see the department starting to see that. So that's a 3-year pilot, $30 million. 30 residential aged care homes will be invited to participate in that. And the interesting aspect of that for me, so absolutely, great to see how we're looking to bring different models of delivery to support better outcomes for our residents, is the fact that they want our sort of supplier of that virtual nursing to bring the technology capability into the homes. Because how we start to connect that information, the flows of information between the virtual nursing back into the home's own clinical management system will be essential. That's obviously where, traditionally those breakdowns or reliance on, sort of paper-based discharge papers, et cetera, have been so problematic. So it's great to see how the technology can actually start to stitch together the system. Obviously a lot more cost efficiency, but, critically the outcomes for the person are so much better when that information and data is moving with them through different parts of the system.
What sort of for we Neanderthals, what sort of technology are you thinking you'll be bringing into, and that's into the residential aged care home, but also into the private home?
Look, there's a number of different components of the technology that are stitched together in that scenario. You've obviously got your telehealth, your video capability, you've got your client management systems, and what's critical, I think, for this, when we were looking at the tender opportunity, so 30 aged care homes that you're tendering for as the supplier of that service, those 30 aged care homes could have various different client management systems that they're using. So there's a lot of work being done, obviously, with the digital health strategy around how we get more sort of uniformity and interoperability across the sort of health system and for us into home care and aged care. So it's not, I don't think it's so much about which components you're using, it's how you've got the APIs to start to share that data securely, protecting people's privacy, the right consents in place, so that information can travel with the resident.
Would it be fair to say, Paul, that it will have to narrow down to 2, 3, 4 providers in the market for the technology? Given that we're going to have public health networks in each state. Each of them have most probably developed their own systems. You're going to have to be able to interact with all of that. You're going to have the Federal Department of Health and their funding, and they want to streamline that. You've got regulations all occurring and evolving. Somebody's got to write all the code to make all that work, and that's just a massive task.
Yeah, right now there's although some would argue that there's an underinvestment of tech in the industry, I think at the same time there is a proliferation of tech available that has historically serviced the market, and one of the conversations that we often have, particularly with a prospective customer, is how much tech, how many systems, how many apps do they have in their business, and sometimes they don't know. For those that do know and they've done an audit, some of them are finding that they've got 50, 60, 80 different apps and systems used right across their organisation. Sometimes that's come about through acquisition over time. Sometimes a single home might be just going out and finding some point solutions, and an employee's swiping a credit card to get access to a small app that does one particular capability. So the conversations that we're often having is you need to narrow that down to a smaller subset of systems. Whether it gets to sort of an end state of 4 providers catering to the entire market, don't know. It might not go down to that level, but I certainly agree with the comments about the need for interoperability, and the need to and there's definitely need to develop a core ecosystem, a relatively small, manageable core ecosystem of capabilities that has resident care at its centre, enabling through the use of APIs, integrations into other technology, be it wearables, be it telehealth system providers, so that you do have that what should be seen as a single source of truth around the delivery of resident care, even though some of those capabilities and functions and data points may be coming from other systems.
And Bev just said that tender is for 36 months, 3 years. The slide from the man from the Department of Health said he wants all this happening in by 2027, which is 3 years. I think things are going to accelerate beyond, gradually doing it. I think it can be well argued that this is going to happen really fast. So, Anita, lawyers, risk. Do you see any risk in this? What would you, in your elevator pitch to clients over hospital in the home, who are doing retirement villages and aged care, home care, what would you be saying?
Oh, look, there's probably 2 main issues, and one is your sort of duty of care, which I'll come back to, but just touching on the tech piece, obviously the interoperability is going to be so critical, but of course that creates real data security challenges and also legal compliance. And at the moment, we've got sort of competing tensions between this need for better communication between systems, but also more public consciousness, I would say, about data security and protection. And that, of course, follows some high-profile incidents last year. And so I think we're going to see some reform in the privacy law and data security space and more regulation. Right now, the privacy and data security law is a bit of a hodgepodge, and say Victoria and New South Wales have regimes in place that govern health information that don't apply in other states, and there's a fair sort of higher threshold in those states. Whereas at the federal level, we've got the privacy law, which doesn't actually marry that all that well with the state laws. And so we've got quite a hodgepodge of regulation in terms of data security, and I think that's going to become even more critical. Because the other thing I would say, whenever I look at people's privacy policies and data sort of retention policies, we see a lot of non-compliance out there. People just don't understand what the obligations are, when they should be deleting information, where it should be stored. Does it have to be stored electronically? Does it have to be stored in hard copy? And I think there are, unfortunately, a lot of gaps out there, and hence why we've seen some of these data breaches. So that's sort of one issue that I think we're going to have to grapple with, and we're going to have to ensure the public actually understand and are confident in those systems and ensuring that their data is actually securely held. And I think, Chris, we were speaking before about how tech is a big part of the system in Denmark. And it sort of occurred to me that the EU has some of the best privacy protection in the world, and that may be why the public is so confident there in trusting their data and trusting their health information to technology companies, whereas I compare that to the US, where your health information could be on-sold to an insurer who may then deny you health coverage. I think you're going to see those competing. We want to sort of get to the Denmark model, I think, where the public are confident in that. So that's obviously the privacy side, but then of course duty of care comes into it when you've got perhaps different services coming in to deliver care to someone in their home or in a village. And of course, one of the things that comes up there is, well, you've got potentially different regulations around that care, and of course, who does the duty of care sit with, and how do we actually make that clear? I'm thinking back to sort of, you may have a home care provider coming into a village to deliver care, or as Verity said, you've got villages who are sort of informally supporting people in a retirement village. And as a lawyer, that just makes me sweat, because you sort of think, oh gosh, what if they don't deliver the care that this person's come to expect that day and something awful happens? Say you're delivering food to the resident, just as an ad hoc thing, they pay $10 a week and you deliver some meals, and the resident doesn't answer, no one sort of checks in, and then a week later you find the resident's had a terrible fall and has been lying there for some days. You can just imagine how that may play out in the public's mind, particularly where we have this conflation between retirement villages and aged care as the same thing, and so much of the public expect that you're going to get that 24/7 care in a village, even when it's perhaps not. It's not really what is part of it. So I think that duty of care is always going to be an issue where you've got multiple services and when you've got this complexity of the laws. And I don't think we've yet quite come to terms with how that's going to work. The home care changes, for example, we're now going to have different service providers delivering care into one person's home. I was talking to one of these service providers recently about how it is they're going to ensure that they have all the information available to them. I understand there's the sort of the care notes will be shared, but then some companies will be using their own systems. It's still very unclear to me, and it seems that there's not a lot of thought yet as to how we're actually all going to ensure that all the information's there and we can meet our duty of care. So those are just some of the issues.
On a lighter note, we did a seminar 3-4 months ago in the area of cyber security, and a lawyer, unnamed, said his advice to clients was to pay the ransom as fast as you can. Is that general advice by the legal community?
I'll leave that to the cyber security lawyers to advise on that. No comment.
Well, the advice was based on the fact that disruption to your business and disruption to your brand, it's a lot better to just pay the money and fight with the authorities afterwards.
Yeah, and look, it's also, by that point, it's almost too late. I mean, the data's been compromised. You've got all your obligations to disclose that to those affected, to disclose it to the regulators. So, yeah, I can see the rationale for that advice.
Verity, with Benetas, when you're looking at your staff, and this technology that we're all talking about, how prepared are they for a more intense technology working environment?
It's interesting. I went recently to the ARIA conference in South Australia. It was interesting talking about tech there, because one of the things that sort of sprung to mind is, you know, a lot of our workforce is ageing, but there's a younger cohort coming in, and they are certainly very tech savvy. I mean, we have problems, they're on their phones when they shouldn't be on their phones. So I'm already starting to think, well, how do we leverage that tech savviness? You know, if I think about some of the new technology that we want to implement soon, one of them will be a new care management system, then how do I get those people to be the champions for the change and actually help us adopt that as quickly as possible and get them involved in even deciding what the platform is that we use? Look, I think people are aware of it, and like anyone, I think people want things that can make their life easier, their job easier, or even more joyful, because it's taking away some of the burdensome tasks that actually take us away from actually delivering care to residents. So I think they know it's coming, but I think, well, I know for myself, you know, I'm of a generation where I didn't grow up with a computer. You know, my high school was handwritten notes, etc. So I think we're all learning, and, you know, we don't even know what's going to be out there even in, to your point, 2, 3, 4, 5 years. It's changing so rapidly. So trying to even predict ahead is tricky. You make the best decision you can at the time you're making the decision, and then you hope you're putting in some future proofing for what may come. So I guess that goes to the point about your platform you choose and how many different apps you have, because that gets you into a real pickle as well. So look, I think largely the workforce wants it. It's just how we help them go there. And look, we're on the same journey as they are.
Chris, we certainly see that tech is an enabler of attracting and retaining workforce. They want a seamless, intuitive experience that enables them to deliver care, not to be stuck doing admin and using multiple systems and so on. And I think as the workforce becomes younger over time, or the younger generation comes into the workforce, that will more and more play out. I think there's also a portion of the industry that doesn't have English as a first language as well. So, you know, there are smarts you can put into the right sort of tech that helps them through that journey as well. Again, with tech that's more intuitive and easy to use, and enables them and shows them how to deliver care.
Thank you. On a more positive note, Bev, this slide that I have up here, which is the indicative roles and services of hospital in the home, not the New South Wales Department of Health's definition, but this is more aligned to yourself or AU or Silver Chain, where prevention and well-being is a significant part of the strategy. Can you explain what Amplar, for instance, is looking to do there? And what the potential is?
Yes, absolutely. So I think, you know, we've spoken a couple of times this morning about the Danish model, Northern European models. Those models are all about prevention and early intervention. They are kind of best in class, acknowledged across the globe. In Australia, we don't yet have a lot of funding available for preventative services. So I think, again, the opportunity for us in retirement living is to say, well, these are really self-determining individuals that have come into the village. They've made the decision to right-size from the family home into an ILU. They're sort of setting themselves up for this next phase of their lives. How do we support them then with products and services that are really about keeping them well and extending their healthy life years? So we at Amplar Health are focused very heavily on how we can enable preventative type programs, health literacy, for people, and that can either be funded, if they're eligible, some of those services can be funded through their home care package, their private health insurance, or self-funding. And retirement villages in particular have got a cohort of people who see value in staying well. That's why they're there. So we have partnered probably about 6 months ago with Amwal. They are an international provider of digital prevention. They work with the NHS in the UK. They work in the US. They have large contracts, for example, with the American Defence Force. And it's all about providing digital prevention programs that are asynchronous. So you don't have to have a person on the other side responding in real time. They're able to use different technologies like web chat, etc. So the different varieties of technology enable people to engage with a clinically evidenced program that are about things like mental health, well-being, nutrition, different programs that are available. And the model being able to be delivered through digital platform is that concept of on demand. You know, you can access through Netflix any movie you like at any time of the day. How about being able to access programs that support your health at any time of the day? And it's through an app-based interface, and it takes you through a program over a number of weeks. It can be purely digital, or we are building options around the Amwell product to build clinical support into that. So that's a bit of a hybrid model between the digital and some of our supports through our clinical teams. But I think it's really for us across Australia opening up new opportunities to really bring prevention to life in a very much more personalised way for the individual, again, on their terms, their device, their time of day. And it really, I think, is a great opportunity for retirement villages to look at, well, what is the range of preventative services that we could offer to our residents, which are really about meeting that core need that they have to stay in control, stay out of resi aged care, and stay well for as long as possible.
But Bev, I'll be the cynic. I've been to over 200 retirement villages. I think Henley on Broadwater is the only village where I've seen the gym regularly used. So when you say that residents, you know, are invested in their health, that hasn't been what I've seen. I've seen them at happy hour.
That's good health too, Chris. There's some social connection happening there.
So, but I did a bit of research, and in Amplar, they are getting very significant positive results of people proactively helping themselves on a digital platform. So can you allay the cynics in the audience, apart from myself, and give an idea of the results?
Oh, look, you know, the thing is that I think it's about the timing of the interventions with people, Chris. So, you know, through our programs with Amplar, it's about, you know, how we are engaging with the members in our private health insurance business at the right time. So there is absolutely kind of a window at times when engaging people with that. But, you do see very successful adherence rates through the programs for people in terms of completing the programs, and then also in terms of the sort of outcomes. We also are building programs for people where, they might have a specific need around knee rehabilitation in the home, and coming out of that program, we might then be able to offer them something around weight management. So we're really looking at those customer journeys and saying, well, what are the right options to surface for people at the right time? So it's not just a kind of spray and pray approach. It's actually very much more personalised to where the individual is at on their journey. But gyms not being well utilised, swimming pools not being well utilised. Everybody thinks that that's a great idea when they're buying into the village, and then no one touches the pool. So I do think it's about how you surface those options at the right time for people.
In the research I did, I saw 92% successful outcomes by a virtual experience with a large number of people through Amplar. So that's the level of success that is being experienced. You were saying through the NHS in the UK in particular, it's been successful along those lines.
Absolutely. And I think it's different options. It's not saying that it's one or the other. It's how do you surface up different options for people, particularly around these digital programs where people can access it at the right time for them. You make it really convenient because they can access it through their phone, and sometimes their programs For example, around mental health, we know sort of during COVID, since COVID, trying to get an appointment with psychologist, psychiatrist, you're waiting anything 4 to 6 months. So these are programs that can be put in the interim period that help give people structure and supports. They are monitored as people are moving through those programs, that there can be an escalation during that period of time as required. But again, it's how we're thinking about health delivery in stepped up and stepped down programs. So it's not sort of, again, you need to see the psychologist, that appointment will be in 4 months' time and good luck with that. So it is absolutely about how we might make those journeys better supported through different technologies.
Verity, with the last point on the bottom right of this slide is self-funding. Benetas, great brand, the massive amount of trust with your customers. How willing are they to self-fund? Because a lot of what we've been discussing will require people to put their hand in their pocket. Is this plausible in your experience?
I think everybody probably would say that that's going to be challenging. People don't like to pay. No one really likes to pay, and I don't think anyone really understands the true cost to provide the service either. I'm not in the home care division, but I know the home care division, there's people that aren't paying their $5 a day for their home care packages, and we struggle to recoup that money. I know when we built, before I arrived at Benetas, we built apartment style model homes, with the 8-bed sort of apartment in an 80-bed home, and people won't pay for that. You don't get a higher RAD because you're living in that kind of little smaller model. So not this generation, maybe next. I really don't know. I think it's a bit unclear. And I think then part of it is, how do we show the value for the money, or there's better information about the cost to provide service, whether there's going to be insurances down the track that people can take out so that they have got that buffer. I mean, even now, the government's talking about those who can afford to pay need to pay more just for residential aged care, and I think there's a lot of screaming about that out there too. So, I'm not sure how that will go.
Okay, so if I could ask the lawyer, if I've got Mrs. Jones in ILU 238 at the end of the street beyond the street, and I know that she needs to have additional services, but she or her family refuse to pay for them, what's the implication for the operator? There's a real health risk there.
There is, absolutely, and of course it will depend to an extent what the relationship is. If you are providing, for example, some home care into that unit, then that's going to be even more difficult. Security of tenure in retirement villages is so difficult. I'm sure there's people in the room who've tried to evict a resident from on sort of health grounds, and it is incredibly difficult. For one thing, unlike in aged care, it's very difficult to actually get a clear picture of their health needs, and if they're not cooperative in the process, then you're not going to get the assessments done that the security of tenure rules actually require you to do. So that can be your first point. There is the option of going to the tribunal, so VCAT, NCAT, whoever it is, to seek that a guardian be appointed. But again, you still need medical evidence to even get into the tribunal. You can sort of try and mount a case without it, but it's a lot more difficult. So again, if you've got a very non-cooperative Mrs. Jones and her family who just say, no, you're not doing any assessment, I'm not letting anyone come in and check on, assess my mother's care needs, then that's a really difficult one as well. And so I think sometimes it almost becomes a matter of putting the person on notice that this is at your risk. If you're going to stay here, we're not responsible. And I know that sort of sounds easier said than done, because it's not what aged care and retirement village operators firstly want to do from a branding perspective, but it also is very much not in their nature. And like Verity said, there's village managers checking in on residents in perhaps a way that isn't structured or formal. And so I think it's a very hard thing to do, to say, well, you're going to have to survive on your own. And of course, that doesn't even take into account, well, what if everyone else around them is complaining? Like Verity said, can it happen? So very, very difficult to get those people out. I find VCAT probably the most effective in that scenario. Just it takes a long time, but you can get there eventually, in my experience.
Answered very well as a lawyer. Thank you for that. But what about the human being, you know, the village manager and the groundsman who know that Mrs. Smith is there and is not in a good state? Well, don't worry about that. We've got the lawyers on it. We'll get her out within 6 months, but she needs help today. It doesn't fly, does it?
No, and that becomes the two issues sort of interrelate, because the more those people go and do for Mrs. Smith, the easier it is for her to say, well, you have to keep doing this for me, or I can stay here. I just need you to keep doing what you've been doing all this time. And so, yeah, it's really, really difficult for staff to sort of be told, no, don't provide any help to that person. But that's sometimes what you need to do.
Don't people have the right to make decisions that we don't think are maybe great decisions? Because really, if she's an autonomous human being, I understand from a village operator and a human side of thing, don't get me wrong, that caring nature in us all is like, this poor lady needs help. But at the same time, people have rights to make decisions. We see it all the time in residential aged care, or people that come into residential aged care very late, and you think, well, they have rights to make decisions that you and I maybe think are not in their best interests, but they've been an autonomous human being their whole lives. Just because they live in a village, do they lose that? It's hard. It's very hard.
It becomes a very grey area whether they've got the competence to be able to make decisions of risk themselves.
Yes.
We've only got about 10 minutes left, and I've been dominating the questions. Are there anybody like to ask any questions of our panel? Yes, up the back.
Yeah, Mike Goldsby. Just quickly setting the scene. Big farmers, huge effort, unbelievable billions selling to all sorts of drugs, e.g. dementia. Secondly, of course, 5%, only 5% of our population in the complex south area consumes 50% of the healthcare costs. And we can keep going on with all the other data. But any thoughts around new technologies, medical technologies, e.g. new MRI machine, which has just been built, 28,000 times better imaging? Where's all the big pharma, big tech going to play into what's sitting about?
Well, I'm not sure I can talk about where big pharma might be going. That's sort of a little bit outside where we play. But certainly we see an increased use of tech to service the industry, be it wearables, falls tracking tools, and so on, and the need for a greater level of interoperability so that data that is being gathered with that type of tech can be brought in and analysed. I think the use cases are still being developed, so can't comment on the big pharma piece as such, but we do know through greater levels of innovation and more spend in tech, the level of care can go up and the cost of delivering care can come down.
Any other questions?
Yes, the cost of care base is interesting. If you implement technology, the biggest cost we have in residential care, for example, is human beings. And we now have a mandated floor that's about to increase. So how can we exploit the benefits of tech? We've got a mandated floor, get our biggest cost.
I mean, I'll sort of offer a view on that. I think seeing the release of the tender from the department around virtual care being able to be delivered into residential aged care settings, for me, is a really positive step forward. You know, the reality is kind of loaves and fishes. We've got a fixed number of RNs and we've got an increasing number of care minutes to deliver. Those RNs aren't rural, regional, remote. So I think, how do we utilise technology then to help amplify the benefit of that workforce across homes, not only at an RN level? How often are you stuck where you can't get a GP in to see a resident in resi aged care? You can't get the locum. Again, virtual telehealth to be able to bring virtual GP to the bedside, gerontologists. So I think technology, like even the department is putting their toe in the water a little bit with this pilot, but I think to the earlier point in terms of just how rapidly this is going to accelerate, because we've got a fixed capacity in terms of our nursing and our GPs and our allied health. we have to find a way for the technology to be able to amplify how many residents those people can support. So I think the department's pilot is very interesting. They are specifically targeting homes who cannot meet those care minute requirements. So I think that's an acknowledgement that technology is going to have a role to play in helping meet those thresholds.
Was there another question?
Yeah, Aaron was Australian Community Services. A big exposure of the Royal Commission was that aged care boards and executives didn't actually understand they had chronic and complex health in their customers. So they lacked clinical governance, they lacked processes, they lacked skills in their workforce. And it's been acknowledged in this room that traditionally seniors living, RV, whatever you call it, is a property play, it is for most of them. So is there a risk, or do you have confidence there's enough awareness in the boards and executives, RV operators, of the clinical risk they're potentially taking on and what it means to their organisational processes, the frameworks, their staff skills, training, and on it goes? When aged care operators couldn't get it right and they had chronic and complex health people at their core every day.
I mean, again, I'd offer a view, Aaron, that there's a continuum. So there are some providers or operators in RV who are very tuned into that. A couple of the examples we've talked about today where they're actually embedding care delivery as part of their core service proposition. And they're taking appropriate steps in terms of clinical governance models and clinical capability on the boards. But there are still RV operators out there who are a predominantly property play, and they might be bringing care in as a partnership, not part of their core proposition, and potentially having that clinical governance and oversight through a sort of separate board through the partnership. So working closely but separate entities. So I think there are interesting models across the sector on how that risk is being managed. But I think the sorts of acuity that we're talking about now, the shortage of resi aged care beds, the very active initiatives to keep people out of EDs and hospitals will mean that the retirement living boards and their management teams are going to have to skill up very rapidly.
Anita, you would have a view on this, I'm sure, because you've got the clients. My observation is that the majority of village operators, there are 30% villages are co-located, 70% are not. Then if they don't have a home care business, their view is we're independent living, we'll bring in a home care service, problem solved. If they have a home care service, they say, happy days, I've got a lot of residents in one place, so this will be easy, this is what we're going to do.
Yeah, I would agree with you there. I think the majority of retirement village clients we come across certainly is still quite of that mindset that they are providing independent living and in some ways perhaps resistive to really integrating care as part of their service offering. But certainly, I mean, people are moving in that direction and starting to recognise it, but I think there's a long way to go before your average retirement village board is going to be sort of clinically, skilled, I would have thought.
But you would agree that the number of clients coming to you and asking for help to move a resident on is increasing.
Yes, absolutely.
So this is the train wreck that's coming towards us.
Mm-hmm. Absolutely.
On that happy note. Sorry, the question at the back, yes?
Hi, I'm Amanda from BestMed. We know it's good to keep people out of hospital where we can, and that the health programs have been going for a long time and have worked. Hospitals are dangerous places and many people die of hospital-acquired infections. But Verity brought up a really good point that I think is very much underplayed, and that's that of advanced care planning. And you said, Verity, that they were and are and can be very uncomfortable discussions to have. Do you think that people understand that they do actually have a choice towards the end of their lives, that when they go to hospital, for example, with a significant pneumonia, they have a choice not to have antibiotics and to die with a syringe driver and family close by? And does the panel think, and anyone else think, that these are discussions that we should be having more in the community, highlighting choice in death and dying?
Yeah, I mean, I'm so on that page. Recently, I just watched a webinar with Kenneth Hillman. He very much talks about, we've medicalised getting old and we've medicalised dying. It's a normal part of life, and I think that, we don't talk about it enough. And probably how many of us in this room have even got an advanced care directive should something horrible happen to us. It's one of the things that everyone kicks the can down the road until often it becomes a very confronting conversation. So look, there's so many factors in this whole discussion that we don't have enough GPs, we don't have enough nurses, there's not enough GPs out servicing people in regional towns, let alone rural and remote. So the healthcare system, I think, is really at a bit of a crisis. Really, I think Victoria is in a real pickle. Those of us who operate in Victoria, we know that there are people occupying beds in hospitals that don't need to be there. I know we're not alone there. I think a lot of the states have that trouble. So I absolutely think that. We're very fortunate at Benetas. I'm really pleased we've just appointed a palliative care specialist. And because we do have retirement living, one of her jobs would be going speaking to people about those sorts of things, advanced care planning, thinking about your future, same with the home care clients. So I'm looking forward to hopefully just making our little modest move on the dial at Benetas anyway, because I can even say in residential care, many, many people come to us without an advanced care plan. And it's not a conversation when you're just admitting mum, dad, auntie, uncle into aged care that they even want to have right now. And then even if you try and have that conversation 6 weeks post-entry, they're still not ready to think about that, even though they're 96, they've got multiple medical issues. It's just, I think, the miracle of modern science, another scanner that can do what for? I'm very much of that sort of way. I'm all for technology when it can be of benefit and make a meaningful difference to someone's life. But I think we all look for that miracle, and, you get to a point in your life where there aren't any more miracles and you need to make some, I hope, some decisions that you can sit with comfortably and, have that dignified death that we hope we all have. But it's not talked about enough, no.
Any other questions? I'll just close off on two things if I can. The first is that in America, you cannot get entry to a retirement village or a CCRC unless you've filled out a full financial statement. It's been confirmed by the solicitor that you've filled out all your paperwork. They just won't take on that responsibility of you entering a village until they have all that work done. And I think we're going to see that in Australia, because the waiting lists now to get into retirement villages is building every day. There is a village down at Berry, south of Sydney, who now requires these things, and it also sells each of its villages by a closed envelope bid. So it's got hundreds of people looking to get into the village, and it picks the 20 odd people who they know have the best means, what the style of resident they want, and they say you've got 4 days to submit a closed envelope bid as to how much you will pay for your village home, and the average hike in price is around 35% that they've been achieving. So I think we're going to see, again, if you just think, I need that safe harbour, I need somewhere for mum, I have the wealth, because we're not building village homes either, we're going to see that. On a lighter note, a very good friend of mine I went to university with is a professor of marketing at UC Berkeley in San Francisco, and he's a worldwide famous brand advertising guru. And for the last 5 years, he's been retained by Pfizer to manage the brand reputation of Pfizer going forward, because 5 years ago, Pfizer was saying that technology, which is basically AI, is going to be so much better than a GP in doing diagnosis, that the GP is going to be redundant. The role of the GP is going to be relegated to being a counsellor, advising the person, this is what the results tell us, and pat you on the shoulder, it'll be okay or it won't be okay. And Pfizer sees it's going to be a 3-year transition between the technology being so well embedded and informing you, to when that everybody's accepting that their main business is from GPs filling out scripts. So if they alienate the GPs, they could lose 3 years of income. So his job, my mate's job, is to make sure when the time is right, they've got a strategy to go out. And that was started 5 years ago. So we are going to see massive change. I think it's going to be here a lot faster than we think. On a positive note, I think we've got a fabulous role, everybody in this room, to implement this change for the betterment of everybody. Can we thank our panel for taking the time to join us? And thank you, Anita and Russell Kennedy, for providing us the accommodation today. Thank you very much.